Thank you for the opportunity to present our research pertaining to young febrile infants and the risk of serious bacterial infections. Our research was supported by several federal grants from the NIH, HRSA, and the EMSC program. There are no conflicts of interest to report pertaining to this study. The risk of serious bacterial infections, which I'll refer to as SBIs, in febrile infants in the first 2 months of life evaluated in the ED is approximately 8 to 10%. Most are due to urinary tract infections, and the rest are due to invasive bacterial infections defined as bacteremia or bacterial meningitis. There are many risk stratification algorithms to help clinicians identify those at risk for SBIs. Prompt diagnosis and treatment are needed for infants with SBIs. However, lumbar punctures, empirical antibiotics, and hospitalizations should be avoided for those at very low risk. Clinical assessment of these infants may be difficult, as many febrile infants with SBIs may not be ill-appearing. There are many protocols for the evaluation of febrile infants, which typically include clinical appearance, the urinalysis, the white blood cell count. Some protocols use band counts or the absolute neutrophil count, which I will refer to as the ANC, and CSF is required for some protocols as well. Many of the prior studies have been suboptimal. Many were small, some were retrospective, and most of the models to predict risk were not statistically derived and used predefined laboratory cutoffs. More recent protocols using newer biomarkers, such as PCT, have resulted in higher accuracy. Nevertheless, there remains substantial variation in the evaluation and disposition of febrile infants 60 days and younger. In 2019, we derived and validated a highly accurate SBI prediction rule in 1,821 febrile infants 60 days and younger in PECARN. 3 objective variables were identified in the recursive partitioning analysis to be associated with low risk of SBI: a negative urinalysis, an ANC less than 4,100, and a serum procalcitonin of less than 1.72. In the original validation set, the sensitivity for this rule was close to 98% and specificity was 60%. The negative predictive value was 99.6% and positive predictive value was nearly 21%. Note that the CSF analysis is not part of the rule, and therefore lumbar punctures are not needed to risk stratify by this rule. There were no cases of missed bacterial meningitis. Of the total 1,821 infants, there were 2 cases of missed UTIs and 1 case of missed bacteremia, all of whom did well. To create a simpler, safer rule, we then rounded the thresholds of ANC to 4,000 and PCT to 0.5. Using this simpler rule resulted in an identical sensitivity as the original rule and only 3% lower specificity. Therefore, the objective of this study was to validate the PECARN SBI prediction rule on a new cohort of febrile infants 60 days and younger using the rounded PECARN variables of urinalysis, ANC, and PCT. We conducted a prospective multicenter cross-sectional study in 21 PECARN EDs from June 2016 to April 2019. We included a convenient sample of febrile infants aged 60 days and younger with rectal temperatures of at least 38 degrees centigrade measured in the ED from a referring facility or at home, and who were evaluated for SBI with a minimum of urine culture and blood cultures, and if no CSF was obtained, then the patient needed to have a follow-up telephone call to verify that there was no bacterial meningitis. We excluded those who received antibiotics within the preceding 48 hours, those with critical illnesses, those with significant underlying illnesses, or those with obvious sources of infection, or those with prematurity less than 37 weeks gestation. Each patient was evaluated with a history and physical examination. A Yale Observation Scale score was assigned to each patient. Unstructured clinical assessment of the risk of SBI was determined by the ED attending, and laboratory testing included a urinalysis, an ANC, a research sample for PCT, and viral studies and other tests were performed at the discretion of the clinician. Treatment and disposition was at the discretion of the ED provider, and telephone follow-up was performed if the patient was discharged from the ED without a lumbar puncture being performed. We defined a positive urinalysis as positive nitrite or leukocyte esterase, or more than 5 white cells per high-power field. UTIs were defined in a standard fashion by growth of a pathogen, with a CFU count dependent on whether it was obtained by a catheter specimen or suprapubic. Bacteremia and bacterial meningitis were defined by growth of a known pathogen. SBI was defined as a UTI, bacteremia, or bacterial meningitis, and invasive bacterial infection, or IBI, was defined by bacteremia or bacterial meningitis. We analyzed the test characteristics of the PECARN rule for SBI using the rounded cutoffs as mentioned. The analysis was stratified by age 0 to 28 days and 29 to 60 days. We calculated the point estimates of risk of SBI and IBI with 95% confidence intervals, and we evaluated infants who were missed by the rule. We enrolled and analyzed 1,363 febrile infants. Approximately one-third were in the first month of life. Approximately 40% were girls. Most had normal Yale Observation Scale scores, and more than 95% had clinical suspicion of SBI of 10% or less. The laboratory results are displayed here. The mean ANC was 4.1, the median PCT was 0.1, and as expected, 9.3% of patients had SBIs. The rate of SBIs was similar between the two age groups, although the distribution of types of SBIs was different between age groups, with a higher rate of IBIs in the younger group. The rate of bacterial meningitis was 0.9% in the first month and 0.2% in the second month of life. As expected, patients with SBIs had higher temperatures, were more likely to have positive urinalyses, and had higher ANCs and PCT levels than patients without SBIs. The test characteristics of the rule overall were nearly identical to those of the original derivation and validation study. The sensitivity was 97.6%, specificity 61.1%, negative predictive value 99.6%, and positive predictive value of 20.5%. The sensitivities for SBI were identical in the first 2 months of life, but the specificity was a bit higher in the second month of life than the first, but this difference did not achieve statistical significance. The prevalence of IBI was 1.8% for the whole group, and the rule was slightly less accurate for IBIs than SBIs. The prevalence of IBIs was higher in the first month of life, and the rule specificity for IBIs was slightly higher in the second month of life. There was one patient with bacteremia missed by the rule in each age group, but there were no cases of missed bacterial meningitis in the whole cohort. There were 3 cases of missed SBIs in the whole cohort, all of whom were well-appearing with Yale Observation Scale scores of 6 and normal laboratories. One was a 56-day-old male with a UTI growing 2 potential pathogens. The second was a 17-day-old male with Staph aureus bacteremia, and the third was a 32-day-old male also with Staph aureus bacteremia. However, this latter patient was evaluated and discharged home without antibiotics. The blood culture grew MSSA at 19 hours. The patient was then called back to the ED, and a repeat blood culture off of antibiotics was negative. A lumbar puncture revealed 249 white cells. The culture was negative, and it was enterovirus positive. We had a few limitations in this study. We enrolled a convenience sample, however, SBI rates matched previous studies on the topic. Although CSF testing was not performed on all patients, we performed follow-up of patients who did not have CSF obtained to ensure they did not have bacterial meningitis. And there were a limited number of patients with bacterial meningitis in the study, but this matches the current epidemiology of SBIs. In conclusion, we validated the PECARN febrile infant rule using rounded cutoffs in approximately 1,400 infants 60 days and younger using 3 simple objective variables, a negative urinalysis, an ANC less than 4,000, and a PCT less than 0.5. The rule was highly accurate, matching the original derivation validation study. Between this and the original study, there have been no cases of missed bacterial meningitis in nearly 3,200 febrile infants evaluated by the PECARN rule using the rounded cutoffs. The implications of this study is that the prediction rule is now ready for implementation, and implementation will limit invasive testing, antibiotic treatment, and hospitalization of these infants. Of note, the rule is only meant to be used in the second month of life due to increased risk in the first month of bacterial meningitis and HSV infections. I want to thank my co-principal investigators, all PECARN site investigators, research coordinators, and data center. I'm happy to take questions by email or Twitter. Thank you very much.